Hallo?
Okay. Okay. Welcome back, everyone, for today's second session this afternoon, in which cardio-renal strategies in our mostly affected patients, the patients with advanced CKD, will be discussed. Nou, dat is makkelijk. Dan switchen we naar het Nederlands. Ja, dan gaan we door met het tweede deel van vanmiddag. En dat gaat over... Toch wel?
Apologies, I am corrected. Everything is recorded and also used for the Australian sites and the German sites as education. They even get post-educational points. When we change to Dutch, I was informed it will probably not happen.
Okay, we'll start again. So you already know today's topic by now, cardio-renal strategies in our patients with advanced CKD. We have two speakers discussing those strategies in our patients on dialysis and after kidney transplantation. And our last presentation will get us out of our cardio-renal comfort zone and is about immunotherapy in our kidney transplant patients. First, I would like to introduce Alferso Abrahams, steering committee member of the Renal Lifecycle trial, PD expert, and he will talk about those strategies in dialysis patients.
Thank you, Lily, for this introduction, and thank you for the opportunity to give a presentation about the prevention of cardiovascular events in dialysis patients. As you all know, cardiovascular disease is a major cause of morbidity and mortality in our patients with kidney failure, and several factors contribute to this increased risk. And here you see the relationship between kidney function and mortality. Here on the left side, let's see this it's working. Sorry. On the yeah, I have another pointer. On the left side, you see on the x-axis the eGFR, and on the y-axis the hazard ratio for all-cause mortality, and here on the right side the hazard ratio for cardiovascular mortality, and you clearly see that there is an increased risk when kidney function declines. And dialysis patients have several risk factors which contribute to this, and besides the traditional risk factors like age, gender, hypertension, diabetes, obesity, dyslipidemia, and smoking, there are also... Use the microphone, please. Sorry? Use the microphone. Okay, yes. There are also kidney disease-specific risk factors like uremia, volume expansion, electrolyte disturbances, sympathetic overactivation, anemia, mineral bone disease, metabolic acidosis, and inflammation. And all these risk factors contribute to this increased risk. And they predispose for cardiovascular disease by several mechanisms which has impact on left ventricular, the left ventricle of the heart, resulting in fibrosis and dysfunction, and all those factors made patients prone for cardiac arrhythmia and sudden cardiac death. So it's very important to treat these risk factors to prevent cardiovascular events in dialysis patients. And in this presentation, I will discuss some treatment options in our population. Statins, phosphate binders, the treatment of anemia, the RAS blockers, the value of implantable cardioverter defibrillators, and the different dialysis modalities. First, statins. In 2013, a Cochrane review has been published, including 25 randomized controlled trials with more than 8,000 patients to address this topic. And as you can see here, they investigated the impact of statins on major cardiovascular events, all-cause mortality, and cardiovascular mortality. And as you can see here, they found no effect of statins on cardiovascular events in dialysis patients. And a recent study from Taiwan investigated the mortality risk using health insurance claims. They conducted a propensity score match cohort comparing statin users with non-statin users. They include more than 40,000 pairs of subjects with normal kidney function, only 400,000 pairs of subjects with normal kidney function, more than 40,000 pairs of patients with chronic kidney disease, and more than 3,600 pairs of patients with end-stage kidney disease, of which about 88% were treated with hemodialysis. In this table, you see the mortality of statin users versus non-statin users. And as you can see here, there was no effect of statins on cardiac heart disease, so cardiac death or heart disease death in patients with end-stage renal disease. They found an adjusted hazard ratio of 0.89, which was not statistically significant. So we can conclude that statins are of no benefit in dialysis patients. What about phosphate binders? In 2018, another Cochrane review has been published to address this topic. And in this Cochrane review, they include more than 100 randomized controlled trials, including about 14,000 patients. And 82 randomized controlled trials were conducted in dialysis patients. And it is of note that there were no placebo-controlled studies included. Here you see the outcome when they compare sevelamer with calcium-containing or calcium-based phosphate binders. If you look at the outcome all-cause mortality, there may be a lower relative effect in advantage of sevelamer compared to calcium-contained phosphate binders, but they did not find effect on cardiovascular death. When they compared lanthanum with calcium, so phosphoronol, they did not find any effect on all-cause mortality and also not on cardiovascular death. And in a recent observational cohort study using Medicare claims data from the USA, they compared sevelamer with calcium acetate in more than 4,000 patients. The patient had a mean age of 75 years, and primary outcome in this analysis was the occurrence of fatal or non-fatal cardiovascular events, defined as cardiovascular death, myocardial infarction, or stroke. And as you can see here in these Kaplan-Meier curves, they did not find any difference in cardiovascular events between sevelamer and compared with calcium acetate. And also in subgroups, no significant differences were found. Here you see a recent paper published in JAMA 2 years ago, where they compared lanthanum carbonate with calcium carbonate on cardiovascular events in hemodialysis patients in a randomized controlled setting. They included more than 2,000 patients from 273 hemodialysis facilities in Japan. More than 1,000 patients were randomized for lanthanum carbonate, and more than 1,000 patients were randomized for calcium carbonate, and the primary outcome was a composite endpoint of cardiovascular events, cardiovascular death, non-fatal myocardial infarction or stroke, unstable angina, cerebrovascular events, and hospitalization for heart failure or arrhythmias. And as you can see here in these Kaplan-Meier curves, they did not find any difference between the two treatment options regarding cardiovascular events. What about iron-based phosphate binders? Is there any effect of those binders on mortality and cardiovascular events in dialysis patients? This question was evaluated in a recent publication using DOP data from Japan. They compared 328 patients using iron-based phosphate binders with 1,300 patients using non-iron-based phosphate binders. Mean age was 66 years. Mean dialysis vintage almost 4 years, and they follow up the patient for almost 3 years. And here you see that there was no difference in cardiovascular events of the iron-based phosphate binders compared to the non-iron phosphate binders. So one can conclude that also that there is no evidence that phosphate binders are of any benefit regarding prevention of cardiovascular events in our dialysis population. I think we should conduct a randomized controlled trial, placebo-controlled, with one of those phosphate binders. But I doubt whether anyone will start such trial.
There's a trial ongoing, the phosphate trial.
Mm-hmm.
It's coming from Canada, in which people are randomized to strict phosphate control or regular phosphate control, hoping to show a difference. But based on the interim analysis, they've increased the power of the study, so going from 2,000 now to 4,000 subjects, suggesting that there is not much of a difference between the strict control and the not strict control. I have to say though that the difference they targeted for would have been rather large, but what they actually are observing is much less, meaning that individual doctors, patients have difficulty adhering to prescription in the trial. So it's going to be a difficult answer, but I agree with you, we cannot at this moment say that phosphate binding doesn't do anything, only that there's no difference between phosphate binders.
I even doubt whether all patients take their phosphate binders, but that's another discussion. What about the treatment of anemia? This is the pivotal trial, probably well known, multi-center randomized controlled trial conducted in the UK between 2013 and 2018, where they compared high-dose proactive IV iron treatment with a reactive low-dose IV treatment. It was a non-inferiority study randomizing more than 2,000 hemodialysis patients, no PD patients included, with a mean age of 62 years, and about 30% had already cardiovascular diseases. Composite primary endpoint was consisted of death, non-fatal myocardial infarction, non-fatal stroke, and hospitalization due to for heart failure. And the secondary endpoints were the primary endpoints as recurrent event, all-cause death, fatal and non-fatal myocardial infarction, fatal and non-fatal stroke, and hospitalization for heart failure. And they're investigated also several safety endpoints. And here you see on the effect, the patients with the event, proportion of patients with the event. And yeah, there may be less events in the high dose group with a P less than 0.001 for non-inferiority, but 0.04 for superiority. So there may be an advantage of high dose proactive IV iron in our dialysis population, at least in the hemodialysis population. There were indeed also less cardiovascular events with high-dose iron in this study, as you can see here, with less fatal or non-fatal myocardial infarctions and less hospitalization for heart failure. But there was no difference in stroke between the groups. So what about the HIF-PH inhibitors, the HIF stabilizers in dialysis patients? What is your experience with the use of these agents in dialysis patients? Do you use these agents in your dialysis population? I see somebody nodding. Yes? Okay.
Yeah, I have a couple of patients on for the same reason. So unresponsiveness and then
with a good response. Okay. Yeah, it could be an indication. However, if you look at cardiovascular of prevention of cardiovascular events, then you could say that there is no difference in cardiovascular safety endpoints of these HIF stabilizers in dialysis patients compared to placebo or ESA. So I think the indication of these agents is quite limited at this moment. So regarding anemia treatment, there might be some benefit, but not very convincing. What about renin angiotensin aldosterone system inhibitors? This question was investigated by Thai. They conducted a meta-analysis published in JASN in 2010, they identified 5 randomized controlled trials with left ventricular mass index as outcome, and 3 randomized controlled trials with cardiovascular events as an outcome. In one study, they investigated candesartan in 80 dialysis patients. In another study, the investigators investigated fosinapril in almost 400 dialysis patients. And in the third study, they investigated losartan, candesartan, or valsartan in 366 dialysis patients. And when you look at the effect of ACE inhibitors and ARBs in this population, then you can conclude that they are not associated with a significant reduction in cardiovascular events, as you can see here. Recently, 2 years ago, this group conducted systematic review and a meta-analysis with studies from 2010 to 2020, and they identified 11 randomized controlled trials, of which 3 studies were done in dialysis patients, 1 with telmisartan in 332 hemo patients, 1 with spironolactone in 253 HD patients, and 1 study investigated eplerenone in 146 HD patients, and also in PD patients. It's only randomized controlled trials, including also PD patients. And if you look at the effect of those RAS blockers in dialysis patients, then they found decrease in cardiovascular events with the use of the RBs and the MRAs, with a odds ratio of 0.52. And another recent study using DOPS data suggests also a possible survival benefit of those agents in hemodialysis patients. So I think that RAS blockers are beneficial in our dialysis patients to prevent cardiovascular events. What about implantable cardioverter defibrillators as a way to prevent cardiovascular events, to prevent sudden cardiac death? That question was investigated in a Dutch multicenter randomized control trial from Leiden University Medical Center. They included 188 hemodialysis patients. 97 of those patients were randomized for an ICD, and 91 were the control patients. They had a median follow-up of almost 7 years, and inclusion stopped for fertility reasons, because they found no difference in the occurrence of sudden cardiac death incidence after 3 years, after 5 years, with a cumulative incidence rate of about 10% in both groups. And they found also no difference in survival, 5-year survival in both groups. On the other hand, they found quite a lot adverse events in patients receiving ICD. With some patients, some patients had adverse events directly related to the ICD implantation. Some patients had problems with the function of the ICD, and in some patients the ICD had to explant it because of infectious problems. So the effect is, there's no beneficial effect, but on the other hand, there are important adverse events. And also, and this result was confirmed in this systematic review, where they include 7 studies in hemodialysis patients, and they found a hazard ratio of 0.77, which is not statistically significant, and there was only one RCT, and that was the ICD-2 trial from the Leiden University Medical Center. So ICD, implantable cardiovascular defibrillators, are also not useful in our population. What about dialysis? That's what we do. Yeah, you can compare the different dialysis modalities. For example, hemodialysis with peritoneal dialysis on the outcome cardiovascular event, and it was, for example, investigated in this meta-analysis, including 28 studies, no randomized controlled trials, but a lot of patients, and they concluded in this meta-analysis that there was lower cardiac mortality in the hemodialysis group. So if you think that that's an important outcome parameter, then you maybe should treat your patients with hemodialysis. I don't think it's a good idea, but another important study is the CONVINCE trial, last year presented at the ERA and published in the New England Journal of Medicine, a multinational randomized controlled trials, including almost 1,400 patients with 683 patients randomized for the high-dose HDF group and 677 patients for the high-flux hemodialysis group. Follow-up was 30 months, and convection volume, targeted convection volume was 23 liters. And here you see that they found a lower risk of death in the hemodiafiltration group with a hazard ratio of 0.77, which was a very important outcome for the investigators. You can also hear the survival curve of the two groups. You see the difference, and the lower of the better survival found in the hemodiafiltration group was also found in pre-specified groups in the patients without pre-existing cardiovascular disease and in patients without pre-existing diabetes, but not in patients with existing cardiovascular disease or diabetes. But interesting, they found no difference in cardiovascular death in this trial. And they found also no difference in fatal and non-fatal cardiovascular outcomes. So it's maybe a surprise. They only found a difference in the infection-related death, and only in when they include the COVID-related death. Of course, the trial was conducted during the COVID pandemic, but yeah, this is an interesting observation. Another recent publication compared home hemodialysis, compared two home treatments, home hemodialysis with peritoneal dialysis, using also US Medicare data claims, including almost 70,000 patients. And here you see that home hemodialysis was associated in the study with a decreased risk of cardiovascular events, especially stroke, acute coronary syndrome, cardiovascular death, and also a difference in all-cause death. What about incremental dialysis? In this systematic review, they compared incremental hemodialysis with conventional hemodialysis. And here you see the results. They included almost 140,000 patients who were included in 36 studies, and they found that incremental hemodialysis may improve cardiovascular outcomes in patients, in hemodialysis patients, when they have enough residual kidney function. So incremental dialysis is possible when patients have enough residual kidney function. So that's important to take in mind. And that underscores, I think, also the importance of residual kidney function and preserving residual kidney function in our dialysis patients, because residual kidney function is associated with several important outcomes, like not only patient survival, but also quality of life, also nutrition, anemia control, fluid balance, and also cardiovascular disease. So maintaining residual kidney function is, I think, an important aim of our dialysis treatment. And in this recently published study, they found also the association between residual kidney function and mortality in hemodialysis patients. And they found a higher mortality risk in patients with a lower kidney function. You see here the residual kidney function on the x-axis, and on the y-axis the hazard ratio for sudden cardiac death, sudden cardiovascular death, and non-cardiovascular death. And they found mortality, lower mortality risk in patients due to cardiovascular events, but also in the due to non-cardiovascular events. So preserving residual kidney function is very important. So with our dialysis treatment, we are able to prevent cardiovascular events. So to conclude, cardiovascular disease is a major cause of morbidity and mortality in dialysis patients, and several factors contribute to this increased risk. However, the treatment options to prevent these events in dialysis patients are quite limited, as you probably already know. So we can have impact on that by our dialysis treatment, but most importantly by maintaining residual kidney function. There is a place for IV iron, for race blockers, and I hope that with the Renal Lifecycle trial we will be able to prove that also SGLT2 inhibitors are of beneficial effect in this vulnerable patient population. But it's not only about survival. In my opinion, we should individualize our treatment to achieve a maximum health-related quality of life. Thank you very much. Thank you very much, and I'm happy to answer your questions.
Thank you, Alferso, for this nice overview. Are there any questions from the audience? Yes.
You did not mention dialysis hypotension. And one of my tutors always said, with dialysis, hemodialysis, you remove as much urea as brain cells. And I read...
Fully agree with the statement.
Recently I read some papers which said that dialysis hypotension is a very important factor in the decrease of cardiac function and other organ functions. Now, what to do against dialysis hypotension? In the institute where I worked, they chose long nightly dialysis for the patients with hypotension. It didn't work. The dialysis hangover of those patients was enormous. And I also have used, in a previous dialysis center where I worked, low-dose noradrenaline, and that worked very well. Patients ended their dialysis without much hangover. But I have not really trials with mortality. Could you comment on dialysis hypotension, what to do and what is the risk?
I fully agree that preventing interdialytic hypotension is very important, also to preserve residual kidney function. It's very important to convince our patients that it's important to restrict their sodium intake. And I think that's an important reason why home treatment, home dialysis, frequent, long is the reason why patients are doing better compared to.
You have a problem with case mix, patients who are suitable for home dialysis.
Yes. Sorry?
Patients suitable for dialysis are not the ones who should be treated by center dialysis.
Yeah, I agree also with that, and I think that more patients are suitable for home treatment than we might think.
We have time for one short question. I saw a question in the back of the room. Okay. Maybe one short question. Can you explain why conventional treatments such as statins to lower cardiovascular risk don't work in the dialysis population? Is it that they are beyond repair, or is it that we have to target different mechanisms?
I think both.
Thank you. Oh, and Ron.
Yeah, probably more people have seen it, but you have presented some data about relative risk reduction of 20%, and it was statistically not significant, and relative risk reduction of 20%, and it was statistically significant. That does not mean that one works and the other doesn't work. It just suggests us that all these trials have been too small, that the power was limited. And that's also one of the things that I'm afraid of course, with the Renal Lifecycle trial, and that's also the reason why I would like to go to 2,000 patients instead of 1,500 patients, because then we have more power of drawing conclusions. And that's why we need your help there. And for dialysis patients, when there are 15 mechanisms for increased mortality, and when you pinpoint to one, for instance, with a statin, yeah, what can you expect? Perhaps 10% decrease. Doesn't mean that it doesn't work, but you have to target all these mechanisms at the same time to help them improve mortality. But these are difficult trials to do, large numbers, or we need a kind of other trial design that we have a multifactorial intervention versus nothing. And perhaps then you could do such a trial with a limited number of patients. So I think that trial design in dialysis patients should be completely different than what we're doing now. The case for SGLT2 inhibitors, where I still think that it can work even when we include only 500 or 700 dialysis patients, is that SGLT2 inhibitors have not only shown to do something on cardiovascular disease, but when you look at infectious mortality, it was also a significant decrease in most of the trials. They don't talk about it. Even cancer deaths are lower. I don't know what's happening with the drug, but this is a one single drug that is intervening on multiple pathways. So there I hope that even with a limited number of patients, we still may have effect in 500 to 700 patients.
Let's go for it.
Okay, thank you, Alferso. And then we move on from the one renal life cycle to the other renal life cycle, from dialysis to transplantation. And then I want to invite Aiko de Vries, transplant nephrologist in the Leiden University Medical Center. The floor is yours.
Is it working? Yeah. So, thanks for inviting me. My name is Aiko de Vries and I'm a transplant nephrologist from Leiden. And I think I stand here humble today after all these previous talks where there's so much evidence, especially also Hilde's very nice overview on SGLT inhibition and other novel medication. And in transplant medicine, there's almost nothing. We're often called the cowboys and the cowgirls because we just prescribe off-label often. We just borrow from CKD, we borrow from hematology or from autoimmune disease, and we just do. So it's not going to be a very beautiful presentation with a lot of trials, but I'll guide you through it. So maybe since this week we're not need to be called cowboys and cowgirls. Maybe the optimal treatment is now xenotransplantation. We need to be called pig girls and pig boys. But this seems to be the future of transplantation since very recently. But I think in the end, all these epitopes, all these molecules are strange. And eventually it's very difficult to inhibit humoral sensitization or humoral rejection against these type of antigens. But we'll see. It's ingeniously done by our colleagues at Harvard. So these are my conflicts of interest. So how did we do it in the past year? In the past decades, better said. When I was an intern at Groningen in 2000, when I started on the renal transplant unit, the mantra was short-term graft survival increased from 60% to over 90%, and long-term graft survival has not improved tremendously, and that hasn't changed ever since. But since that period, and it was in 2000, Harry Herron has updated his survival curves, and what you can see is we're still doing a better job altogether. Both the transplant centers and the nephrologists in the periphery, we're all doing a much better job. You can see in slide A and B the patient survival, which is increased only slightly, unfortunately, but also graft survival, long-term graft survival over the age is still improving. So very slowly we're doing a better job. And the Leuven group actually followed up on this. They used the CTS database, which is the European Collaborative Transplant Study database, which predominantly focuses on brain-dead transplantations. So it's not all transplantations. But what they showed, and you can see in the graph D, is that especially 10 years death-censored graft survival improved more so than short-term graft survival over the past decade. So we are doing a better job, and I hope with perhaps new medication as SGLT inhibition, we can do even a better job. And this is in spite, and I'm sorry, the titles were all in Dutch, so I created my slides in Dutch. This is in spite of the fact that our donors and recipients are on average 10 years older now than they were 10 years ago. So these are very recent Nephrovision data where you can see that the percentage of 75-year plus transplant recipients and the 65-year plus transplant recipients are steadily increasing over time. And despite that, we are still improving outcome. Yet the two major reasons why we experience graft loss are still recipient death, and then we lose the graft as well as what they call death-censored graft failure. So these are still the two main important items in transplant medicine. And if you look at the first one, the recipient death, I mean, this is still a dominant cause of transplant failure and of patient failure. You can see that the causes of death over time change. A large part is still malignancy, a large part is still infection, especially in the immediate term after transplantation, where immunosuppression is still quite high. But sudden death, often by cardiomyopathy and acute arrhythmia, and cardiovascular disease are still dominant causes of patient mortality. So this is very, very important. And also, we often ignore it because we never like to look at the unknown or other causes box, right? We don't know what it is, it may be bad registration, but there's still a lot to learn. We don't know all the causes yet of patient loss. Personally, I think it's also very interesting nowadays to look at the environmental factors like oncogens, but also the climate change, drought, water scarcity, and nephrotoxins in the environment. I'm very curious. We recently mapped our acute rejection rates in the Leiden area to where people live, and there's a clear difference on where people experience acute rejection. So I think, and this is a very recent call only by this week, combined from the ISN, the ERA, and the ASN, to look more at the social determinants and also the environmental factors that are contributing to CKD. But transplant patients, we all know that have an increased risk for cardiovascular mortality. And this is a very familiar slide, adapted by Foley. This is already a very old slide, where you can see that especially for the young transplant recipients, mortality has increased tremendously. And as you age, obviously, death becomes imminent, and obviously the increased risk diminishes over time. But this is still a very increased risk. So what are these cardiovascular risk factors in transplant recipients? Well, you can divide them in traditional risk factors, age, cardiovascular history, sex, smoking. You can also look at the traditional CKD and uremic risk factors, such as being on dialysis or having had a preemptive transplantation. Whether you still have a patent AV fistula, or what, as we call it, a shunt. Your calcium phosphate product, your kidney function, your LVH, uremic toxins all contribute to cardiovascular risk factors. And this has a lot of overlap with their dialysis history, as you heard before. But it's also the fact that many transplant recipients experience metabolic syndrome. They have obesity, they have dyslipidemia, they have hypertension. The majority, far over 90%, has hypertension. And up to 30% may develop post-transplant diabetes. So they're also prone to metabolic syndrome. So I'm not going to cover all of these risk factors because you have heard much of on these topics already today, but I want to show you a little bit that is often forgotten. And if a transplant patient has a patent AV fistula, it's one of the most stronger correlates of left ventricular hypertrophy. And this is a very small trial published in Circulation in 2019 that show if you ligate the fistula, you get an almost 15% decrease in left ventricular mass. So it is a factor that might contribute to the increased cardiovascular risk as well. And this slide was by the courtesy of Joris Rotmans at our department. But there was also a very strong reduction in NT-proBNP, and remember that I'll come back to that enzyme a little bit later, and also in left arterial volume. So especially the lower arm shunts, if they have a very high fistula, what we call the beat flow, then that really gives an additional stress to your heart and left ventricular hypertrophy. Now the proof in the pudding is ligating. So in the data on left ventricular hypertrophy are more clear. However, the data on kidney function, kidney transplant function, are less clear. They're more conflicting. So here you see two studies where they close the fistula, and in one study on the left you see a slowly decrease of eGFR, and on the right you actually see an increase of eGFR. So I think the jury is still out on the effects of AV ligation on renal transplant function. As I said before, and this was also one part of my old PhD studies in Groningen, is the majority of transplant recipients at some point in time develops the metabolic syndrome. Which definition you use doesn't matter. Most have it. And partly this pertains or is caused by our immunosuppression. So cyclosporin contributes to post-transplant diabetes, especially to dyslipidemia and hypertension. Tacrolimus, is now the current standard, contributes to post-transplant diabetes predominantly, but also to dyslipidemia and hypertension. mTOR inhibitors contribute to dyslipidemia. Steroids, especially higher dose steroids above 5 milligrams per day, contribute to the metabolic syndrome. And there are some immunosuppressive drugs like Myfortic and belatacept and azathioprine, which have less metabolic side effects, but they're not always the standard. I think the current standard of TAC, PrET, and NPS still contributes to metabolic syndrome. But it's not just the medication that we prescribe. It's also that obesity in general is becoming a growing problem in the world. And this is already a very old slide. And if you look to the lower curves, this is presence of obesity at time of transplantation, before the patients get transplanted. And you see that over time, the percentage of obese transplant patients is increasing, even more so than in the general population, probably because obesity is a risk factor for end-stage renal disease in general. However, and I think this also reflects on Ron's remark that I think in the Netherlands, it's still not as bad as in the US. So here you see the more recent Nephrovision data where only 5% of renal transplant patients at time of transplantation have type 2 diabetes, and 9% has hypertension as a cause for end-stage renal disease, and still a large majority has glomerulonephritis or polycystic kidney disease. So I think even though our population is getting obese as well, we're still behind, for instance, the US. But if that would not be enough, then this is also beautiful research from Groningen, done by Doreen Zelle. Even after transplantation, patients get an appetite. They increase 10% often within the first year after transplantation. And she investigated that not only BMI increases, but this is predominantly fat mass. It's not fluid retention, it's not lean muscle mass, it's predominantly fat mass. And that was associated with physical activity and also with diet. So less fruits and vegetables and increased energy-rich drinks. So it's not strange. On dialysis, patients often learn what I call the wrong diet, at least for the general population. You can't have too much fruit and vegetables because of potassium. You cannot have protein because of phosphate. But they all have malnutrition and inflammation to a certain extent, and then they need carbohydrates and fats. And if you continue that diet after transplantation, then that might contribute to post-transplant weight gain. And it's not just the steroids, because you see almost a similar increase in weight in patients who are weaned off steroids eventually. A very important risk factor is post-transplant diabetes. And here you see the incidence of diabetes before and after transplantation, and the red line is tacrolimus and the black line is cyclosporin. And here you can see that tacrolimus conveys an increased risk for the development of diabetes after transplantation, more so than cyclosporin. And why is this? Because a lot of people say, well, tacrolimus is a more powerful calcineurin and fat inhibitor. But if you really look at the studies, NFAT and calcineurin is inhibited almost equally, both in islets and in lymphocytes by cyclosporin and by tacrolimus. So what explains the difference between the two? And it's probably not the NFAT inhibition per se that explains the whole story, because NFAT is not constitutively expressed in mature beta cells. It has an important role in the development of beta cells, but not in mature beta cells. And, but it's likely the chaperone proteins, so which is FKBP for tacrolimus and cyclophilin for cyclosporin, and they have off-target effects, almost like DAPA. There are many off-target effects. So FKBP has a role in insulin secretion on iodine receptors. They have a role in many other cell functions, and they also activate TGF and BMP receptors. It's like a cork of the FKBP is like a cork, like a stop of the BMP TGFB receptors. And also we did some research on this where you can really show interaction, synergy between metabolic stress from obesity and dyslipidemia with the effects of tacrolimus. So metabolic stress increases nuclear shuttling of a protein called FOXO1. Tacrolimus increases another protein, SMAT1. Together they form a complex, and you see almost a de-differentiation of your islets, very similar to type 2 diabetes. So partly it's regular risk factors, obesity, metabolic stress. Partly it's caused by us, by giving these drugs. But of all these risk factors, what is now the dominant risk factor for the increased mortality? And this is an old study done in Groningen as well by Leendert Oterdom, where he looked at the increased risk of the Groningen renal transplant population compared to the general population sample from PREVENT, and adjusted for each of these cardiovascular risk factors. And the two most dominant risk factors are NT-proBNP, fluid overload, or heart failure, or cardiorenal interaction, and creatinine clearance, renal function. So even for cardiovascular death in renal transplant recipients, having a good cardiorenal function is very, very important. So this brings me to death sensor graft loss, and why we lose grafts over time. And the Leuven group met Elisabeth van Loon looked very intricately at all the causes of late graft loss. And you can see here, there's still a large part in red, which is non-specific chronic injury, and we don't really know what causes graft loss. But there's also a large part that's caused by alloimmunity, by acute cellular and antibody-mediated rejection, the development of antibodies against HLA predominantly, next to hemodynamic factors and infections like BK nephropathy. So it's basically a mixed bag. And Phil Halloran from Canada also looked at the risk factors for death sensor graft loss, and he also stipulated them by time. And here you can see that in the beginning, of course, you have early onset antibody-mediated rejection, which is basically immunological screening and risk stratification up front before transplantation. Then T-cell mediated rejection is a very dominant early on. Then you get BK nephropathy. And in the long term, it's chronic antibody-mediated rejection. It's non-adherent rejection. And other renal causes, which is, for instance, a return of IgA nephropathy or calcineurin toxicity or hypertensive nephropathy or diabetic nephropathy from post-transplant diabetes. So basically, this is kind of a CKD category, and it all ends up, without sometimes knowing the exact cause, to chronic scarring, to interstitial fibrosis and tubular atrophy. And so there's an overlap between death-censored graft loss and death with a functioning graft. And the Clemens Buder group from Charité in Berlin really looked into this, and they looked at what is a primary cause, what is a secondary cause. So if you have, for your immunosuppression, for instance, a malignancy, and you will get chemotherapy or immune stimulators, you might end up with rejection. So it's not often it's often a chicken and egg story. So it's kind of a mixed bag, which means that if you want to optimize your transplant function, you need to take everything into account. So you need to take into account the non-immunological factors. So how was the quality of the donor? And how is the quality and the lifestyle of the recipient in terms of diabetes, lipidemia, hypertension, and what is caused by our medication. So you want to reduce the medication as much as possible, but at the same time, if you lower the medication, you might develop de novo donor-specific antibodies, or cellular rejection. So it's finding the proper immunosuppressive balance. It's like sailing between Scylla and Charybdis, and that might be different for every patient. So how do we do it? Basically, we try to go as low as we go. We try to find non-toxic alternatives of immunosuppression. However, and this is a kind of a slide of the recent trials in immunosuppression. The Elite Symphony was a large trial with tacrolimus and everolimus and mTOR inhibition, and then came the belatacept trials. But to be honest, not much is being developed for the field of transplantation anymore. I think tacrolimus, cell-prednisone, or perhaps tacrolimus, everolimus is the current standard. And I do foresee more impetus with xenotransplantation, because you will need new co-stimulation blockers like belatacept, and belatacept it's good on the cardiovascular risk profile, but it's quite difficult to give it to every patient because it takes a monthly admission on a daycare with an intravenous infusion, and unfortunately it's not yet on the market as a subcutaneous syringe or subcutaneous injection. If novel co-stimulation blockers will arrive, I think there will be a market for them. But also, we're trying to use the cell therapy, like mesenchymal stem cell therapy. And currently, there's also a trial ongoing in Rotterdam, Leiden, and Groningen with CAR T-Rex, so regulatory T cells, where we try to reprogram your military police cells that have immunosuppressive properties to target the kidney and have local immunosuppression. And then we can hopefully lower the toxic drugs that we give patients. But how do we monitor our patients in the outpatient clinic? Well, it's kind of an easy job. So if you cannot do anything else, you can become a transplant nephrologist, because we just look at transplant function. But it's a quite late marker for alloimmunity, because we know that proteinuria develops late, and we know from protocol biopsies that patients can already have rejection in the kidney without the creatinine or the proteinuria showing it. Very importantly, we'll look at trough levels of our immunosuppression, especially tacrolimus. And in Leiden, we even try to personalize that based on an AUC, on the exposure of medicine. And we also look, not in every center, but more and more, to donor-specific antibodies. If they develop and they're subclinical, that means if we can detect a donor-specific antibody against the HLA of a graft, and the creatinine is still stable, and the proteinuria is still normal or stable, then there's a 50% chance there is rejection on a protocol biopsy, if you do a protocol biopsy then. And 15% T-cell rejection, so not always humoral rejection, and 40% humoral rejection. However, as long as there is no proper treatment for antibody-mediated rejection, you can question the validity, or you can question the health economics of measuring donor-specific antibodies in your outpatient clinic. And we look for complications, so infections, cardiovascular risk, and malignancies. And the new things that are on the horizon, and there's also research done in the Netherlands, in a European, together with Vienna and other centers, is looking at the reactivation of a non-pathogenic virus, tortinovirus, and look at the level of latency of this virus. Can we, as a functional measure of immunosuppression, look at the reactivation of that virus and titrate our immunosuppression to the level of latency? Which is not unlike the lung transplantation, where they often lowered immunosuppression as soon as EBV started to reactivate. And this is very close to what we already do in practice. But as long as everybody still has tacrolimus, basically it's how low can you go? And there's not much evidence on that, and also obviously depend on your immunological risk. But there is some evidence. So here you can see a study from WEEP and also from the CTS on the right, Kenar-Suzal. On the first, the endpoint is the development of donor-specific antibodies, and on the right, the endpoint is graft loss. especially in the younger population. And what you can see is the message is almost the same, is around the level of a trough level 4 to 5 in tacrolimus, you start to see significantly development of donor-specific antibodies. And obviously this is a mixed bag. This is not stratified yet for immunological risk. And also 4 to 5 seems to be the lower trough level for graft survival. But that is the amount of evidence that's out there. There's not much more. So Sufjan, who is present here, also did some modeling on our database. And he also showed that for BPAR, for biopsy-proven acute rejection, 5, the lower trough level of 5 seems to be a good lower trough level to prevent rejection. And if you have very low intrapatient variability, like if you are very stable every time on your trough levels, it's 4.8, 4.7, 4.9, and not suddenly 3 or 6 or 8, then probably the lower level can be 4. And this intrapatient variability is very important, because it's not just that one time that patients take their medicine properly and come into the outpatient clinic. It's also, do they take their drugs at home every time right? So you can also, because you have a kind of a therapeutic interval, and if it's below the interval one time, in the interval the other time, and then the third time it's out of above the interval, then you have a high intrapatient variability. So stressing adherence and stressing a regular intake is still very important in the outpatient clinic. And Kano Suso also showed that if you have a high intrapatient variability, your graft survival is less. How about cardiovascular risk? Well, there's not much evidence out there, and de Lond developed 2 guidelines at this moment for post-transplant hypertension and post-transplant dyslipidemia. It basically says there's no evidence that prioritizes any antihypertensive drug. So both ACE inhibitors or calcium antagonists or anything that you can have is appropriate, which goes a little bit against the DAPA study where you need to have an ARP. But there's no evidence that ACE or ARP inhibition in transplant patients has any clear benefit.
In the transplantation strata, you don't need to have an ARP or ACE. Is that right? Or it's only in the...
Yeah, okay, good. So, and then for post-transplant dyslipidemia, we basically copied the CKD guideline where we say everybody can have a statin. However, we have some difficulty with preemptive transplanted 18-year-olds who have a kidney function of 90% with a good kidney from a brother or a sibling. So we added 0.2. So if a patient is younger than 50 years and the eGFR is above 60, doesn't have any albuminuria and a very low risk for cardiovascular events, then one can contemplate not giving a statin. But for the rest, basically the advice is to give every transplant patient a statin. However, the uncomfortable truth is the majority of patients don't have the appropriate medication in our patient clinic. I know Groningen has a dashboard looking into how many patients are under conservative therapy. We have a dashboard and we can do better. Now, in terms of post-transplant diabetes, we had a consensus guideline and it predominantly said lifestyle modification, oral antiglycemics, and insulin. However, recently we changed that to this. We said general recommendation is metformin, but if you have CKD, heart failure, SGLT2 inhibition, obesity or established cardiovascular disease, GLP-1, and perhaps insulin instability or other cases like. Now, this guideline also says there's very limited evidence to prescribe DAPA because it's probably safe. We know it from CKD. Don't be afraid of it. I'm prescribing DAPA to my diabetic outpatient clinic, transplant outpatients, and very rarely do they develop any complication. But there are 2 studies done, and I'm almost finished. One is the SGLT inhibitors in kidney transplant patients with post-transplant diabetes, and this is a retrospective study done in Asia with almost 2,000 transplant patients and 226 had SGLT, and they showed a clear reduction in all-cause mortality, in graft failure, and in doubling of serum creatinine, which shows some promise, and it was a control, a propensity score matched control population. Now, this is not the dominant evidence, I'm aware of that, but this is what's out there. And there are only very few limited studies with only 10 to 15 patients. And this is the second. This is a Spanish study with 300 transplant patients. And what they showed in a subgroup analysis is UTIs were similar between diabetic kidney transplant recipients treated with SGLT2 inhibitor over 12 months compared with non-diabetic. So personally, I'm not afraid of urinary tract infections in our transplant patients, especially because having more than 2 is a contraindication for participation. So, in conclusion, kidney transplant has an increased cardiovascular risk and increased CKD, but optimize the balance of immunosuppression, probably not below a TAC level of 5 or perhaps 4 if somebody is really stable. And please do proactive cardiovascular risk management. I think it should be also focused on heart failure and kidney function, and also think about a patent fistula. And I think, to be honest, that SGLT inhibitors can have a very profound impact.
Thank you, Aiko, for a clear overview of the causes of cardiorenal problems in the kidney transplant patients, and also how to optimize kidney transplant health in our patients. Are there any questions from the audience? Maybe, yeah.
One question about the shunt. What do you call high flow? Would you like it if shunt flow is less? Because that's always a dilemma.
Well, we don't prospectively follow up on all the flows, so I don't think there's any evidence to really have a hard cutoff. But sometimes you see a patient with cardiorenal issues, and you do a shunt flow, and it's on the upper arm, and it's 2.4 liters per minute. Then we would consider ligating.
But that's obvious because there are already cardiac symptoms. But when you
Yeah.
do it in a preventive manner to prevent cardiac problems, and the shunt flow is like 900.
Yeah.
Do you ligate that shunt?
In a trial, yes. We don't prospectively measure it with everybody, so we do it on an ad hoc basis if patients have an issue and think, oh, is the shunt still open? But your question is differently. Your question is, do it prospectively, and is there a cutoff? And I think there's no evidence for that yet.
But I was asking, in your experience, what do you do in your center?
I think it's above 1.5 liter, then it gives you quite a stress to the heart. But that's my empirical clinical experience. But again, thanks.
Well, actually, I had a question similarly to that, because you mentioned that maybe we should proactively act on cardiovascular risk management. So would you then think that we should characterize our pre-transplantation candidates better in terms of presence of heart failure, or maximize their therapies? Maybe SGLT2 inhibition also does something on ischemia reperfusion, and that we do that, that we don't do that as well as we should.
It's a good question. I'm not sure I have the perfect answer. So, to be honest, I think Adnan Sharif showed that a lot of cardiovascular risk that we do and that we screen up front is basically for the perioperative cardiovascular mortality. But there's no parameter or determinant that is very dominant in determining that cardiovascular risk. So we do it, but do we then decide not to transplant? Moreover, a lot is reversible, also depending on the amount of kidney function that a patient gets. Or even with the AV fistula. We had a patient who was denied transplantation because of a poor cardiac function, had an ejection fraction of 27%, but it was probably measured before dialysis with fluid overload, and she had a patent fistula. And we said, we ligated the fistula pre-transplantation, gave her a catheter, and because she still had a low ejection fraction after dialysis when there was no clear signs of fluid overload, and the hypertrophy was reversible and became 36%. So we as a second opinion, we gave her a shot and we transplanted her. And that is something that, so what is reversible? And we don't really know that. And it also depends on the patient and the kidney mix. So if you have a good living patient and you transplant a lot of glomeruli, much might be reversible.
Yeah, because also the high incidence of heart failure related events in that first post-transplant period does maybe let us think otherwise, that it's not as reversible as we think.
In my experience, a lot of the cardiomyopathy and fluid overload can be reversible. Obviously, the ischemic vascular disease, less so, and the microvascular disease from diabetes also less so.
Okay, thank you. Any other questions for Aiko? No? Thank you, Aiko. And we move on to our last speaker. That's Dr. Hilde Jalving. She's an oncologist at the Groningen University Medical Center, and she will elaborate on immunotherapy in kidney transplant patients.
Thank you very much, and thank you for inviting me. Completely out of my comfort zone here, but at least my knowledge on cardiovascular risk management has been refreshed a bit. I think it's now my task to keep you awake until the drinks in half an hour, and to take you out of your comfort zone. So I'm going to tell you a little bit about the recent developments in immunotherapy for patients with especially skin cancers, which are I think the cancers that you see most in your transplant patients. So you probably know all of this. The risk of cancer increases in a number of years after transplantation. This is true for all cancers, but especially true for the non-melanoma skin cancers, so especially the cutaneous squamous cell carcinoma, and a little bit for the other types, which I'll show you in a moment. Question which people ask is, should you screen for all of these cancers? You know this better than I do. There are extensive guidelines, but what I could see is, especially the skin cancers, it is advised to do a regular screening by a dermatologist. So a little bit of pathophysiology about the skin. So this is the skin as you know it. The squamous cells are just under the epidermis. So this is where the squamous cell carcinomas develop. You have, of course, the melanocytes, which develop into melanoma, which we're not going to talk about today. You see the basal cells, the basal cell carcinomas. And then we have these really strange cells called Merkel cells, which are a type of neuroendocrine cell. Pathologists can spend whole conferences discussing what the origin of these cells is, but they seem to be neuroendocrine, and they can also develop into cancer. So how often do we see these different skin cancers? So melanoma is not very common, but relatively common. Merkel cell carcinoma is very, very rare. Squamous carcinoma of the skin is very common at low stages, but very rare in the metastatic setting. Same is for basal cell carcinoma, also very common in the primary setting, but extremely rare in the metastatic setting. So as a medical oncologist, I see a lot of melanoma patients. I see very, very few Merkel cell carcinoma patients, and also an increasing number of squamous cell, but also this is maybe 10 to 20 patients a year per treatment center, which is very centralized. I'll show you that in a moment too. So how about in transplant patients? Because those are the patients that you're taking care of. We know that the risk of squamous cell carcinoma may be increased up to about 60-fold. For the lip, it's about 20-fold. Also, basal cell carcinoma is more common. Melanoma is more common, and also Kaposi sarcoma is more common in transplant patients. So what are the risk factors? Like for any patient developing skin cancer, the skin type is a risk factor. Patients transplanted at a higher age have a higher risk. Obviously, the length of immunosuppression, the type of immunosuppression, and the dose leads to increasing risk. There seems to be a higher risk for cyclosporin compared to everolimus. A previous transplant is a risk factor. I'm not sure whether that's due to the total amount of immunosuppression or something else. And also patients who have an other autoimmune disease have an increased risk. Is this changing? Probably. What you know more about than I do is that your immunosuppression schedules are changing. And this is a very nice cohort of patients from Scandinavia, in which you can see the risk of different cancers in the years after transplant of different solid organs. So the kidney at the top in all cases, which is the blue line. What you can see in the cohort from 1983 to 1992 is that the risk very much increases with time. You see the same in the cohort 1990 to 2002, and it seems to be getting less. Although, as you'll notice, that this curve obviously ends at 10 years, it seems that the risk of developing cancer is reducing, and that's probably because of more prudent use of immunosuppression. So how do we take care of patients with metastatic skin cancers? So it's very centralized. For melanoma, we have 14 treatment centers in the Netherlands. For the squamous cell carcinoma, 5. And for the Merkel cell carcinoma, 4 centers which spread across the Netherlands. For all of these tumors, we do a lot of biobanking data collection to see whether the trials, which I'll show you in a moment, are also reciprocated in our real-world data. Okay, so what does cancer do with the immune system, or the other way around? So just to quickly take you through the cancer, what we call the cancer immunity cycle. So a cancer grows quickly, but also dies a lot. So there's a lot of apoptosis in cancer cells. The idea is that the dendritic cells or macrophages take up these parts of these cancer cells, present them to the T cell. If they recognize an antigen as being non-self, they can divide, and they should go back to the cancer to clear it away. Obviously, if that happened properly, we wouldn't have a job, so things go wrong. And they go wrong especially for cancer at these steps. So the step where the dendritic cell presents antigen to the T cell, and the step where the T cell go back to the tumor to try and clear it out. So I'm not sure this projects so well in the sun, but this is the interaction between the dendritic cell and the T cell. What you see is obviously the antigen presentation, and then you have activation signals and you have inhibitory signals. And what immune checkpoint inhibitors do is that they inhibit the inhibitory signals. So in that way, they boost the immune response. And this happens at the interaction dendritic cell T cell with CTLA-4 inhibitors, so a drug we call ipilimumab, and also at the effector phase where the T cell goes to the cancer cell. Here again, the cancer cell antigens are recognized by the T cell receptor, and here you have a negative regulation, which is the PD-1 and the PD-L1, which can interact. And both antigens have antibodies which we can give to prevent this interaction. So you get rid of the negative interaction and activate the immune system. And this has worked really well for several cancer types, also led to the Nobel Prize for the people that discovered this. And I'll show you a little bit why. This is just to show you what type of cancers are sensitive to immunotherapy. So along the x-axis, you see the number of somatic mutations. So how different the tumor is to self. And here you see the response rates to immunotherapy. And what you can see all the way at the top corner with a very large number of mutations and a very high response rate are the squamous cell carcinoma patients. And that's because it's almost all sun-induced. So almost all squamous cell carcinomas are in the skin-exposed section, so head and neck. And they respond very well to immunotherapy. You see here as well mismatch repair deficient tumors, which obviously have a problem in fixing mistakes in the DNA repair. You see melanoma, also sun-induced. You see the Merkel cell carcinomas here. They're a little bit strange. I'll explain that later. Here, quite high as well, you see the lung carcinomas, so the smoking-induced cancers. So especially cancers that are sun-induced, smoking-induced, are very responsive to immunotherapy because they're very different. Okay, so a little bit about squamous cell carcinoma. So as I said, mostly in the head and neck area, there's a premalignant lesion, which we all know is the actinic keratosis. Risk is very much increased after transplantation. As I showed you, 65 is probably times the risk is probably an old number. It's probably a bit lower now. We often see locally advanced disease. That can be a problem without ever having distant metastases, but patients can also develop distant metastases. Risk factors for advanced disease are comorbidities and especially immunosuppression. So what can we do? This is an example of one of our patients with permission to show the picture. We can give patients chemotherapy. It works a little bit for a while, maybe 2 or 3 months. Not something we do standard. Countries around us give standard chemotherapy for these patients. We don't feel that the benefit is enough. The same is a targeted therapy against the EGFR receptor, which is overexpressed in this tumor. Also, some responses, but all very short-lived, and also this has not become standard therapy in the Netherlands. But then came immunotherapy. So this is one of our patients in an immunotherapy trial before this became standard of care. So you can see a very extensive locally advanced disease, which had been initially resected when still possible, multiple courses of radiotherapy. At that point, when there are no other options, he enrolled on one of the immunotherapy trials. And this is what you see. After 3 months, you see already a very large improvement, and after 5 months, almost complete resolution. The exciting thing about these drugs is these responses are long-lived. So we can stop the immunotherapy and patients continue to respond. So the patients that do well really do well. And that's what makes it so challenging when we come to the transplant patients in a moment. So this is a waterfall plot of cemiplimab, so it's anti-PD-1 therapy in patients with cutaneous squamous cell carcinoma. So I don't know how used to waterfall plots you are, but this shows the change in the size of the measured tumor lesions. So this is if they stay stable during the trial, this is if they increase in size, and down is if they reduce in size. And what you see is that the very large majority of patients have response, and there's only a very small proportion that progress during treatment. These are the Kaplan-Meier curves, all phase 2 trials. This is too rare to really be able to do a big phase 3 trials, but because the results have been so impressive, this has actually led to registration of these drugs. You see 3 separate curves. So the highest curve doing best is the locally advanced squamous cell carcinoma, and the 2 lower curves are 2 different cohorts of metastatic patients. And what you see is this response rate of about 50% really long-term responders, where you see that in the first maybe 2 years after starting, the curves are still dropping, and after that, they flatten. And that's what makes everyone so enthusiastic, because we really think that we might actually be curing these patients. Nobody dares to call it that because these drugs haven't been around long enough, but the results are impressive for the patients in which it works. Moving to the neoadjuvant setting, so patients that have irresectable tumors, it's obviously logical to see whether you can make these tumors smaller by giving immunotherapy up front. That's not standard of care yet, but I think it will become standard of care quite soon. So patients get 2 cycles of immunotherapy before surgery. And if you then look at the surgical specimens, again, you see a very, very high response rate for these patients. Just 2 slides on Merkel cell carcinoma before we dive into the data for the transplant patients. So Merkel cell carcinoma is a strange cancer. There's 2 different routes of pathogenesis. The first is the Merkel cell polyoma virus. So that's a virus which 80% of us have on our skin at any time. Usually we don't have any problems with it, but very occasionally you have a viral integration into the genome and you get expression of a large T antigen, which inhibits p53 signaling. And p53 is one of the major tumor suppressor genes, and that results in oncogenic transformation and also presentation of these viral peptides. These viral peptides make these tumor cells very different from normal and also make these cells sensitive to immunotherapy. The other route of pathogenesis is through sun exposure, similar to the cutaneous squamous cell carcinomas. So for both types of pathogenesis, tumors are very different and also very sensitive to immunotherapy. That's also what you see. So similar data to the squamous cell carcinoma, you see a nice survival curve which flattens out. You see a good waterfall plot which shows good reduction of tumor size independent of whether it's viral pathogenesis or not. And here you see that the patients that respond, they continue to respond for quite a long time. So do we know which patients respond and don't respond? There's a lot of things we don't know yet. One thing which is important if we're thinking about transplant patients is that we know that if you look at the patient characteristics and the group of patients that are doing poorly, it's a group of patients that start treatment with immunosuppression. So that's important. The other thing is we know that immune therapy seems to work better when we treat patients early during their disease with a low tumor load. So those are things that we need to take into consideration. Just something about the side effects. Obviously, if you're playing around with how strong your immune response is, you're going to cause problems as well. You can activate almost any autoimmune disease with immunotherapy. So everything from arthritis, colitis, hepatitis, everything can be induced. Surprisingly, 80% of the patients do really well, are a little bit tired, a little bit of joint pain, a little bit of dry skin, but are going on holiday, working, and living relatively normal lives. About 15% of patients experience serious side effects, and that can be anything from the skin is quite frequent, colitis, also hepatitis quite frequent. Obviously, you guys are probably interested in the nephritis, which is low, probably underestimated in trials because we oncologists tend to look at the previous creatinine and then 3 weeks later we see that it's just about the same. So I think if we'd look back to the baseline, we might catch a little bit more. The other thing which is interesting is the timing of the side effects. So with chemotherapy, patients get sick in the first 3 weeks. Side effects immunotherapy can happen at any time. You see that the first side effects start to arise after 4 to 8 weeks, but there's also first incidence of side effects after a year of therapy. So it can always have gone well, and suddenly you get these immune-related side effects. What's worrying if we think about the transplant patients that we see a negative effect of immunosuppression. So this is data from melanoma patients who developed a side effect and needed to be treated with second-line immunosuppression. And you see that the patients that are treated with steroids plus second-line immunosuppression do worse than the patients treated with steroids only. So that means that we try and get it under control with steroids, these side effects, and only if we really don't manage, we add in second-line immunosuppressants. Okay, so on to the transplant patients. So the last time I gave this talk, I did a complete literature search, and the evidence base is very poor. It's obviously a retrospective series, some of a few patients up to, I think the largest series, about 120 patients. This is a relatively good summary of one of the studies, and it really reflects the results of the other studies as well. So this is a retrospective cohort study, 23 institutions. They had about 70 renal transplant patients, and all these renal transplant patients had a cancer which needed immunotherapy. So either anti-PD-1, PD-L1, or CTLA-4. What did they see? They saw acute rejection rates of about 40%. That's what other studies see as well. Most rejection was in the first few weeks, so median time to rejection 24 days, and 65% of patients lost their graft. That's the negative side. The positive side is that 36% of patients with squamous cell carcinoma had really good responses, and 40% for melanoma. So you're seeing not quite as good responses as in patients without a transplant, but still quite good numbers if you think that these are ongoing responses. But obviously this is a worry. And then a renal transplant is still maybe a bit more is less scary than patients that have, for example, a heart transplant, because often you do have an alternative. But if you think about it, and you have a patient with cutaneous squamous cell carcinoma, which can't be treated with local therapy, you've got a situation where you have an effective therapy which will give you 30-40% really good responses, but also around 50% chance of losing your graft. And that's a difficult balance to make. So what about immunosuppression? Can we influence this chance of rejection and response by playing with the immunosuppression? There's even less data for this. What it looks like, obviously, if you have more immunosuppression, you have less chance of rejection, but probably less chance of response as well. So for the tacrolimus, for example, 26% of patients had a rejection with tacrolimus and 49% without, but also the response rates were lower in patients with tacrolimus. The patients in which it was possible to reduce the immunosuppression before starting treatment did better. And then all of these very small trials say different things about which immunosuppressant is doing better. This is one of the studies where they looked at single-agent immunosuppressive therapy versus combination. And then this column is the allograft rejection rates, and this is the tumor response rate. And obviously small numbers, but what you seem to see is that with the calcineurin inhibitors, you have lower rejection rates, but here also much lower response rates. And maybe combination immunosuppressive therapy seems to be the middle ground, where you have relatively low response rates, but still relatively high, relatively low rejection rates and still relatively high response rates. But this is all very marginal evidence, so this is something that you really need to decide on an individual patient basis. One prospective clinical study started just before COVID and unfortunately stopped during COVID because of lack of accrual. 17 patients treated, of which 9 cutaneous squamous cell carcinoma, were treated with anti-PD-1. They saw 1 patient with rejection and 1 with rejection possibly starting, and they had 53% responses. So very similar to the retrospective data. And they have a lot of data on HLA mismatches, but obviously all very small patient numbers. Then there was one other randomized study which is still ongoing, where they upfront put patients onto a regimen with tacrolimus, low-dose prednisolone, and nivolumab, and then randomized to either keeping the same immunotherapy or adding in a second immunotherapy drug. The interim results were very poor, so they had very low response rates and a couple of rejections. So this trial has actually been amended to include an mTOR inhibitor instead of the tacrolimus, but those results haven't been presented yet. So what do we do in practice? If there's a patient with cutaneous squamous cell carcinoma, we first see whether local treatments are possible. So surgery when possible, radiotherapy when possible, even for metastatic disease in 1 or 2 locations, see whether you can treat it with local measures before you have to go to this immunotherapy. If you're stuck and you really can't do any more local therapy, it's really a shared decision. So what we often do is we inform the patients together with their transplant nephrologist and really go through the options, the chances of response, the chances of rejection. And these discussions can go any way. There's patients who say, I've done dialysis for years, no problem, I'll go back. And there's other patients who say, you know this better than I do, I'm never going back on dialysis, then I'd rather die from my cancer. And those are the kind of discussions that you have to have, and the best way to do that is really in the clinic together with the transplantation nephrologist. One quick case before we stop. So this is one patient we treated. So she had a second transplant and increasing incidence of skin malignancies, as I'm sure you'll recognize in practice. This was her immunosuppression schedule, and at this point she developed metastatic disease. She was tapered off most of her immunosuppressants, and the prednisolone dose was increased, thinking that we're probably best off with just one type of immunosuppression. She was then treated with cemiplimab, so anti-PD-1, and had a complete remission of her skin cancer. So these are pictures. This is the original lesion. This is an FDG PET scan before treatment, where you see the primary lesion and also extensive metastases, which completely disappeared after cemiplimab. She also retained her graft function, and this was actually reported as a case report, but unfortunately just after publication she relapsed with extensively metastasized disease. So I have to be honest that it's not quite as nice as that is on this slide. One last note, I'm sure you know this. This is a randomized study looking at the prevention of skin cancer in transplant patients. So 120 patients with a kidney transplant all had a previous cutaneous squamous cell carcinoma, and they were randomized to switch from a calcineurin inhibitor to sirolimus or not. And they looked at the chance of developing a new skin cancer. And there you see that the sirolimus group had a better survival without a new skin cancer than the calcineurin inhibitor-treated group.
But it's survival without a new cancer.
Without a new cancer, yeah.
That's the important message, that you don't prevent new tumors. I think when you switch to sirolimus, I think you postpone a new one. Switch early.
Yeah. Yeah, and I suppose the question is what your goal is. I think, you know, the small, if you have really good control and you can get rid of these small tumors, it's you know, that it's not the big problem is if they get too big or start metastasizing. Yeah. Okay, so take home or take to work messages. You all know that there's an increased cancer risk, especially cutaneous squamous cell carcinoma. If this is happening often, always consider reducing immunosuppression, which I'm sure you do anyway. Remember that immunotherapy really works well, but in transplant patients, it's really an individual patient choice whether you choose to go down that avenue or not. Thank you.
Well, thank you very much for this very nice overview. Are there any questions from the audience? I see a question there. I'll bring the microphone.
Are there any case reports of a retransplant after a treatment for squamous cell cancer? Do you know
That's a good question.
Perhaps.
Not that I'm aware of. I know we've discussed it previously with our transplant team. I think that's something you'd be very worried about, that because you continue to have an active immune system, because that's the reason why we think we can stop these drugs at one point, and you continue to have a response. So I'd be very worried that you get rejection. So I suppose with scarcity of organs, and I don't know how to make this just because I think we don't know, and obviously there are patients that don't lose their graft. So who knows? But yeah, it wouldn't be the first choice, I think. Yeah.
Any other questions?
I
Hi.
was wondering, is it the continuous activation of the immune system, or is it the induction of memory which leads to a sustained response? Because I can't, because that's why I was curious about the side effects in the emergence of autoimmune diseases thereafter. Does the risk decrease at a certain time point? But then you can say that's mostly maybe generation of memory, because we had the discussion about the same issue as was mentioned before. Can we do a retransplant in a patient who was treated like that?
I mean, what we know about the side effects is that the biggest chance of side effects is in the first 3 to 6 months. So the risk of developing new side effects during treatment after 6 months is much lower, but not zero. I think it's very rare to see new side effects more than 3 months after stopping. So we've seen side effects occurring even after stopping, but we know if you look at the pharmacokinetics, these drugs stay in the body a very long time. We dose this drug every 3 weeks, but if you look at the pharmacokinetic studies, you can probably dose them once every 6 or once every 9 weeks. So they stay in the body for a long time, but I'm sure it's memory as well. And I think we don't understand enough why we can stop these drugs. Have we killed all the tumor cells, or are they just there relatively dormant? And is it a balance between the immune system and the tumor cells? We just don't know.
Any other questions? And I have one last question. I noticed from your slides that the efficacy of the checkpoint inhibitors was less in younger patients. Do you have an explanation for that?
Yeah, Depends on the setting, because we know most about this in patients with melanoma, and surprisingly, it seems to be relatively similar in older and younger patients. So we expected older patients to have an exhausted immune system and maybe it not work so well, but actually it seems to work equally well in older patients and in younger patients. I think what you're probably seeing in the graphs is that younger patients tend to get, you know, quite aggressive cancers which grow quickly. Maybe that's more of the bias there. But if you really look at matched cohorts, surprisingly, young patients and old patients' immune systems seem to react the same. And because the side effects are relatively low. I mean, you have a risk of serious side effects, but most people do well. We sometimes treat, you know, fit 85, 90-year-olds. I mean, you can discuss where we need to stop, but it's hard because if you see these big tumors, it's also, if you leave that to grow, it can be a huge palliative problem as well. When you know that you've got a drug that can induce responses, and even if you can't cure someone, you might make their last time a little bit better if they don't have a big ulcerating wound.
Thank you very much. Yeah, this was the end of the symposium. I want to thank you all for your attendance. I think, at least if I speak for myself, I'm inspired to do even more effort to include patients in the renal life cycle trial. So thank you all, and I want to invite you for drinks now.